Another Puscast. Lucky you. This one covers the last 2 weeks of February 2016. References, as always, are available online at edgydoc.com, where you will find links to my growing multimedia empire. And if you are unaware, Volume 2 of The Puss Whisperer is now available on Amazon. So now you can have a matte set of puss whispering. Otherwise, I don't know what I'm going to do this time. I normally go over about maybe 1,000 titles to come up with usually about 40 papers. I want to talk about half of those. I got 87 papers this week, and there's no way I'm going to cover 87 papers in 30 minutes, although some of them are kind of just, hey, look at this type of reports. So we'll see. But let's get on to the literature, shall we? Worries about Zika virus continue, not unexpectedly. And it will be interesting to discover what happened to this virus that made it change to the point where it causes microcephaly. What are the 2 or 3 newest things since we last talked about Zika virus? One, it seems that the earlier in pregnancy that a female acquires a Zika virus, the more likely they are to have problems. So first trimester seems to be particularly worrisome. But if you get Zika in your first trimester, miscarriage and microcephaly maybe are more common, although the number of patients involved in this MMWR report are fairly small. And so the data is increasingly pointing to Zika as the cause of microcephaly, Guillain-Barré, and other problems in the fetus. There is a nice perspective. Zika virus in the Americas, yet another arbovirus threat. Another arbovirus threat. It's a threat as well. It's in the February 18th New England Journal of Medicine, and I commend it to your attention. Ooh, don't I sound English? We're still finding out some of the problems of Ebola as well. There is apparently a post-Ebola syndrome where patients have myalgias, headaches, and ongoing ocular problems in that order, as well as a hodgepodge of other symptoms. How much of this is due to Ebola versus a post-almost-died syndrome is uncertain, but certainly Ebola can persist in the eye long after it is eradicated from other organs. And they need to do better matched prospective trials to know if this is indeed the case. But given how sick people are and how Ebola tends to persist in some body fluids, I'm not surprised that people have ongoing problems after being infected with this virus. And unlike African Ebola with aggressive supportive care, in the West, in this New England Journal article, 81.5% of people with Ebola survived. That's pretty good. There's a thing in medicine also called premature closure, where you quit thinking about a patient because you think they have a given disease. I see this all the time in travelers, where as soon as someone comes back from Africa, everyone thinks of malaria and nothing else. Emory looked at their evaluation of patients with suspected Ebola, none of whom turned out had Ebola. And instead, their symptoms were an interesting hodgepodge. Influenza A, influenza-like illness, acute diarrhea, malaria, influenza B, rhinovirus infection, ETEC gastroenteritis, blastocystis hominis gastroenteritis, and a case of diabetic ketoacidosis. All that glitters is not gold. All who wander are not lost. All that have fever from Sierra Leone are not Ebola. Keep your differential broad. And as long as we're on the topic of mosquito-borne plagues, can you get West Nile more than once? I would have thought not. I would have thought that antibody would have been protective. But there's a series of patients out of Israel with what they called non-primary West Nile virus. They called it non-primary because they could not tell whether it was reactivation versus reinfection. But all these patients had sky-high IgGs, negative IgMs, and West Nile DNA present. They had a higher mortality rate compared to people with primary West Nile, about triple, and the same amount of neurologic symptoms. So, in at least some subsets of patients, having had prior West Nile infection may not be protective against future and maybe fatal disease. Going backwards in time for plagues, how about HIV disease? There have been studies in the past that suggest that screening for Cryptococcus is a good idea. In this study out of Africa, 4.5% of patients presenting with HIV were screened for cryptococcal disease with an antigen and found to be positive. They were treated with fluconazole and were the better for it. They used CD4 counts of 100 or less as a cutoff for screening for cryptococcal disease. Although living in the Great Pacific Northwest, where Cryptococcus is becoming more endemic, I would be inclined to use 200 CD4 cells or below for my cutoff for routine screening of cryptococcal disease. We know that HSV increases viral loads of HIV in women, but what does the use of HAART do in women with herpes? The good news is if you have HSV and you're on HAART, highly active antiretroviral therapy, your viral shedding of HSV goes down. Well, and finally, in the world of HIV, you worry about the transmission of resistant virus from person to person. Some HIV patients will self-cohort and say, oh, I have HIV, you have HIV. We don't need to worry. They found that the rate of transmission of resistance was around 8%, which is pretty good. And part of the reason why when you start HIV therapy, you should check a genotype first just to make sure that what you're giving is going to work. We are having flu season now, and the good news, the flu vaccine is better this year than last year. Last year it was a whopping 18% effective. That kind of stinks. This year appears, at least by early data, 59% effective in reducing the risk for influenza. Still not great, but it's like seatbelts. I'd rather be wearing seatbelts if I had a head-on. I'd rather be having the flu vaccine during flu season. If you're going to be giving it to your pregnant women as opposed to your pregnant men, I know I've said that joke a billion times, our study of only 36 patients suggests that you get a better response if you give it in the first trimester rather than later in the pregnancy. And those of us in ID always like to point to the 1918-1919 pandemic of influenza, which killed about 650,000 Americans, which is how many Americans died by gunshot wounds or shrapnel, combat deaths in other words, in all our wars put together, which is pretty impressive. The 1918-19 pandemic was a bad one. But the 1957-1959 pandemic had about tenfold greater deaths than the 2009 H1N1. That they have estimated in a recent study to have caused 1.1 million excess deaths. Or as an anti-flu person would say, only 1.1 million excess deaths. Flu kills, vaccines help prevent that. I think it's a good idea to go out and get your vaccine. I keep harping on the relationship between infections and stroke, heart attack, or other vascular events, and how some vaccines, like childhood vaccines and influenza vaccine, probably prevent stroke. And this study looked at herpes simplex and the association with arterial stroke in children and found a relationship. And they suggest that perhaps herpes simplex viruses may trigger stroke in children, and that in some of these kids, the infection is subclinical, as is often the case with herpes. But this is yet another infection that leads to, or at least is associated with, a stroke. As I like to point out, if those whack-a-loon therapies really could boost your immune system, i.e. lead to an inflammatory response, it would probably also boost your risk for a stroke. Fortunately, you can't boost your immune system. That's nonsense. It will, however, boost the amount of money in the wallet of the person making the recommendation. Pertussis has been booming in the United States for a variety of reasons. In 2012, for example, there were 48,000 cases, a record since 1955. Why would that be? One of the reasons may be the new vaccine, which is not as immunogenic as the old pertussis vaccine. But also it may be that the use of the vaccine has led to changes in the types of pertussis that have been circulating. This study did pulse field gel electrophoresis, which is not a real fine tool, to look at the strains of Bordetella wandering in the United States, and they found there have been changes year to year. Also, interestingly, this has seen the emergence of a pertactin deficient Bordetella. Pertactin is important immunogen in the vaccine, but there are now deficient strains, and perhaps the poorer vaccine has led to these deficient strains of pertussis. Exactly why Bordetella is coming back gangbusters is probably due to multiple reasons. But no good deed ever goes unpunished, and perhaps switching from a more efficacious and more side effect vaccine to a less efficacious, fewer side effect vaccine has helped lead to the reemergence of pertussis. A pair of Yersinia related articles. This one concerns the scarlet fever-like syndrome that's associated with Yersinia pseudotuberculosis, another report out of Russia. And genetic analysis suggests that a single strain causes most of the scarlet fever-like syndrome associated with Yersinia pseudotuberculosis, the organism having acquired a couple of plasmids that makes it virulent. I mean, I'm nobody from nowhere, but this sure reeks of a potential board question. Again, not that I have any inside track. And as long as we're on the topic of Yersinia, and there was a report out of China looking at the clinical cases of pneumonic plague that were sporadic in that country. They were all in herders, and it was suggested that their dog was the intermediary that brought plague home. This has been a recurring theme in plague in the world. People find their sick dog, or their sick dog comes home, their dog out killing rodents and other vermin, and then bring the bubonic plague home to the family. So I think it's important that if your dog is out playing in the fields, before you allow it inside, autoclave it. Now that we have these respiratory panels, I keep getting all these viruses found in patients on bronchoscopies and with pneumonia, and they frequently have rhinovirus isolated. What the hell does that mean? This study at least looked retrospectively at critically ill patients with rhinovirus and found that they had a bunch of problems associated with it. Dyspnea, seizures, exacerbation of lung disease, secondary bacterial processes such as pneumococcal pneumonia. Still not certain what the rhinovirus's role in all this is, and we still need to sort that out in these ICU patients. Whether or not these are true and unrelated, or in fact the rhinovirus is causing or exacerbating these problems, still needs to be sorted out. Now, bacteremia is bad for you short term. We all know that. But how about long term? Turns out getting infected with a bloodstream infection is not good for you. In patients with Staph aureus bacteremia, within 1 year, 62% of the patients had died, and 72% within 5 years. If you were age 65 or older, 82% died after their Staph aureus bacteremia. Old people and women tend to die of, or at least with, or as a consequence of, or following, however you want to phrase it, Staph aureus bacteremia. Just how much the staph contributes to the death versus a marker needs to be identified. But this is true of just bacteremia in general, that people who develop bacteremia are more likely to die in the next 5 years. What do they die of? Well, cancer. You'd think that bacteremia would help their cancer, tumor necrosis factor and all. And cardiovascular disease. Oh, yeah, infection leading to vascular complications. Again, is this a marker of underlying disease, or is this causal? That still needs to be worked out. But certainly, even if it's a marker, you can tell the patient not to get any long-term subscriptions. So, getting back to REMIC leads to your later death. Can you do anything about it? Maybe. This was an interesting study that looked at outcomes in patients who were involved in a decolonization procedure before surgery. Patients either got decolonized for their staph carriage rate or got placebo. Patients who got decolonized had fewer surgical infections. Okay. But interestingly, there was a reduction in 1-year mortality in the surgical patients who got decolonized. In the mupirocin chlorhexidine group, 11 of 365 died, 3%, versus 7% or 21 of 301. So is getting rid of staph carriage protective of dying later? I don't know. It's intriguing. I think, of course, as is always the case, further studies need be done. Q fever is a chronic infection that occurs late in Coxiella infections. There's now described in CID a new clinical association between acute Q fever, the development of a large vegetation, and, here's the key thing, antiphospholipid antibody syndrome, whatever the hell that is. Actually, I do. And they also suggest that patients with new onset of anticardiolipin syndrome be evaluated for acute Q fever. I don't live in Q fever country. I've yet to see my first case despite looking, but I still have a couple years to go. There remains this ongoing issue as to whether or not you can prevent recurrent urinary tract infections by giving antibiotics. Generally speaking, I think the answer is trending towards no. This was interesting. They looked at the effect of Bactrim being used for pneumocystis prophylaxis in kidney transplant patients, and they found it did not prevent asymptomatic bacteriuria. It did not prevent urinary tract infections, but it did lead to antibiotic resistance, not surprisingly, amoxicillin and TMP sulfa. So in a population at risk for UTIs, the use of Bactrim didn't do any damn good, which is a pretty consistent finding. Generally speaking, if you have to rely on antibiotics to prevent an infection, it's not going to work, except in very special situations. It's a marker that I'm getting old and grumpy, but there are two things that I think are so often treated so stupidly with infectious diseases. One is people mistake an aspiration event for an aspiration pneumonia and give anaerobic coverage, and that's too stupid for words. The other is the treatment of soft tissue infections, specifically outpatient cellulitis, and people seem to do a remarkably bad job about it. There's one study that looked at the clinical situations of people who fail outpatient antibiotics, and they found that these patients were no different than patients who did just fine clinically. They got admitted, probably, from what I can tell in the literature, paranoia on the part of the doctor. So often people don't do a good job of evaluating cellulitis. Specifically, they don't raise the extremity higher than the heart and mistake chronic lymphedema or acute lymphedema for infection. The rubordolar-Kalar tumor of infection stays when you elevate above the heart, and I cure more infections than I can count by raising the leg higher than the heart, and all the redness goes away. In this study, however, they found that it was MRSA, not other organisms, that were a big cause of recurrent infections. They say that 3% had gram-negative rods, but I think those are probably all likely to be colonizers. The other study is an archetype in clinical trials whose sole design is to sell drug. It was a major article, right, in Clinical Infectious Diseases that looked at a single dose of dalbavancin versus a follow-up dose of dalbavancin a week later in the treatment of soft tissue infections. And they found that the two therapies were equal. Why anybody would give this drug for acute cellulitis eludes me. It costs as much as a fully loaded MacBook Pro, and there's simpler, cheaper ways to take care of cellulitis, almost all of which is due to streptococci. Cellulitis, of course, being a diffuse erythroderma. And if you got a boil or an abscess, that needs an IND, not a drug that costs as much as a fully loaded MacBook Pro. This was, of course, sponsored by the pharmaceutical company, and I think is an archetype for a study that need never be done and only exists to sell a drug that nobody needs. And I'm shocked to find that the authors had stock in the companies and were employees. And it showed benefit. I'm shocked. This kind of crap belongs in a throwaway journal, not as a, quote, major article in the Clinical Infectious Diseases Journal. Sometimes I swear to God my society and might have no standards whatsoever. There's been this fascinating literature, mostly out of Europe, to suggest that patients with herniated discs get secondary infections of their disc, often with P. acnes, and they get what are called modic 1 changes on their MR, which is edema on bilateral end plates. So it has been suggested that patients with certain changes on their MR with herniated discs have a secondary infection. There's also a clinical trial where patients were randomized to Augmentin versus placebo, and then what had the Augmentin got better faster. However, Augmentin ain't no placebo given all the diarrhea it causes. This study, however, cultured people doing an anterior approach instead of going through the back. And they found positive cultures in only 1.6% of their patients, 2 of whom had P. acnes, and none of them had biopsies that suggested neutrophilia, so they think that all their cultures were negative. So this is interesting and goes against the literature out of Europe, which is primarily a posterior approach that acquired the cultures. So it's an interesting question still. Are these backs infected or not? And is the ongoing problem in the medical literature for every study, there's an equal and opposite study? I don't know. I'm still intrigued by the MR changes that they may be due to infection, but then I think everything is due to infection. The usual number I tell patients when they have a positive PPD is they have a 5% chance to get TB in the first 5 years after being exposed, and about a 5% chance of developing TB lifetime thereafter. Is that true? Well, maybe not. In this study, it was actually closer to 10 to 15%, depending on the population in the year after exposure. If you were a kid less than 5, 56% developed active TB. So the risk of TB after exposure is probably higher than we have said in the past. And for hoots and giggles, how many latent tuberculosi do we have in the United States? 12.4 million, of which 73% are foreign-born. But that's still a lot of latent TB in the United States. So how about other weird mycobacterium? Well, there was an outbreak of Mycobacterium marinum in a New York fish market. It was primarily in Chinatown. It turns out Mycobacterium orygis, O-R-Y-G-I-S, causes tuberculosis in free-ranging rhinoceri. There's nothing quite as delicious as a good free-range rhinoceros. There's a report on Mycobacterium mucogenicum bacteremia in immunocompetent patients. How about Mycobacterium microti, found in dairy goats in France, and it's caused occasional diseases in humans, so that could be a potential reservoir. There's cases of Mycobacterium arupense, A-R-U-P-E-N-S-E, as a cause of tenosynovitis. And finally, be wary of rapid growers in patients with implantable cardiac devices, especially if you're putting it in a rhinoceros or a dairy goat. Mycobacterium, they're everywhere you don't want them to be. Yes, I'll take methylotropes for 50. What the hell is a methylotrope? I will quote the article. Methylotropes are versatile environmental bacteria that can use single carbon organic compounds as their sole source of energy. And which names do they go by? Watch me mangle them. There's Granulobacter bethidensis, Acidomonas methanolytica, and Methylobacterium lucitanum. How's that? Probably messed them all up. Why do you care? Because there are reports of patients with chronic granulomatous disease getting infections with methylotropes. That sure as hell will be on some board question somewhere. The question is, how will I remember it? The presentation in these patients tends to be lymphadenopathy, which can include a necrotizing lymphadenitis with or without abscess formation, and they also have elevated inflammatory markers. They are sometimes fatal in these patients. And each of the different methylotropes have different culture requirements as well as antibiotic susceptibilities. I'm going to have to look up to see if the 16S ribosome test can isolate these. When to think of it? When patients have chronic necrotizing lymphadenitis and chronic granulomatous disease. Then quickly Google and find this article in Emerging Infectious Diseases, and you'll know where to go from there. Again, for every study, there's an equal and opposite study. In 2013, there was an article in the New England Journal of Medicine that suggested that those with new prescriptions for macrolides can have fatal ventricular arrhythmias. Now there's another study that shows this ain't so. They looked at 600,000 seniors who had a macrolide antibiotic and compared to those that did not, and they did not have an increased risk of a ventricular arrhythmia in the subsequent 30 days. So maybe there is, maybe there isn't. I'm still leery about giving macrolides, quinolones, and azoles to people with cardiac conduction issues, especially quinolones. Those antibiotics are good, but they're also evil. They're the Jekyll and Hyde of antibiotics. I guess that's it. Not bad. 27 minutes. A lot of other articles I downloaded are likely to show up in the compendium rather than on the podcast. They're more fine-tuning of some of the drug choices and epidemiology of diseases. Now that we've come to the end, it's the usual rigmarole. You can find the references at edgydoc.com. You can go to iTunes and write me glowing reviews. You can go to Amazon and buy Puss Whisperer Volume 1 and 2. And you can erase this feed from your phone and never listen again. It's nice to have options in life, isn't it? So, as always, thank you for listening, and thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, in dictation, and goodbye.